Now, if Vikki Chandler-Vizard, who is a transfusion practitioner from the University Hospital Dorset and is based at the Pool Hospital, is going to give us a talk on specific requirements, risks and consequences. So Vikki, if you'd like to take control.
Right, so my name is Vikki, thanks for holding on there, and thank you, Cara, for the introduction. So I'm a transfusion practitioner on the Pool site of University Hospitals Dorset, but prior to being a transfusion practitioner, I was a BMS in the lab for 12 years, so I absolutely know what it's like to be newly qualified, to be lone working. You've learnt all your policies, your SOPs, and you're just waiting for whatever turns up into the lab, whatever you're requested for. And I think the hard thing with transfusion is that we can have as many policies and processes written as we like, but all clinical situations vary and can be quite different. So what makes a great BMS is the ability to take those policies, to take those SOPs and apply them to any clinical situation that you're in. So I've got a couple of scenarios that we're just going to go through, sort of looking at how we apply those rules. So the first situation we're going to talk through, so we have a male patient who's come in through the emergency department. They have a known historic group on the lab system that's APOS, and we've got a group and screen sample that's arrived into the lab with a request for 2 units of red cells as soon as possible. We also have on the limb system a historic flag requiring irradiated blood components. The only clinical details that we've been given is that the patient's HB is 63. So based on this information right now at this point, what do we know? Well, I know that it's about 8 o'clock in the evening and I have no routine deliveries from the NHSBT until the following day. In my stocks, I have 1 unit of APOS irradiated red cells, and I have also a unit of OPOS irradiated blood. So I can start to make a plan, start to make a decision. There's more information I need though. So this historic flag for irradiated components, I need to know if that's current, is that active? Is it a historic flag from in the past when a patient was receiving some sort of treatment? Or is this a flag for a diagnosis such as Hodgkin's where the irradiated requirement is lifelong? So there's more information I need to find out about that. The indications, triggers, targets for the transfusion. So I can see the hemoglobin is 63, so that meets national triggers based on hemoglobin alone. But what's the target for this patient? They've asked for 2 units. Is there a reason that they've asked particularly for 2 units? What are the clinical details? So is the patient bleeding? Are they stable? Are they symptomatic? So trying again get the kind of the urgency and the need for that request. And also don't forget you have your clinical colleagues available to get this information, so you can speak to the clinician requesting the component to find out a bit more, and you've got your clinical haematologist that might be able to help you with whether or not the irradiated requirement is still relevant. So a bit more information about the patient then. He is stable, he's not bleeding, but he is symptomatic, so they definitely do want to transfuse sooner rather than later. So we've got a couple of options. We can just transfuse the 1 A positive irradiated unit, and then if they do want a second unit, deal with that a bit later. We could meet the group requirements, so we could transfuse 1 APOS irradiated and 1 APOS non-irradiated. Or our third option is that we could transfuse an APOS irradiated and an OPOS irradiated, which meets the irradiated requirement. So let's take each of those scenarios. So scenario number 1, we just transfuse 1 APOS irradiated. We do need to think about whether or not that second unit is necessary. We can obviously chat with the clinician, with the team looking after the patient, transfuse that unit. We know good practice looks at single unit transfusions and assessing the patient between units transfused. So we know that the patient isn't bleeding and they're relatively stable. So we've got time to do that. We've got time to transfuse that 1 unit and assess them. And it may be that that second unit isn't necessary tonight and they could wait until tomorrow perhaps. But equally, potentially there could be a delay if they do want that second unit and we want to stick to APOS and irradiated. Option 2, so transfusing an APOS irradiated and APOS non-irradiated. Well, this very much depends on the special requirement. Is that irradiated requirement necessary? And this is where, again, talking to your clinical colleagues and the time frame of this situation can change your answer. If we're in a more of an urgent situation and the patient is bleeding, then actually our most urgent requirement is to get compatible units available for that patient. So it may be that we don't see the irradiated requirement as being so important. But in our situation, actually, that the patient isn't bleeding, so we do have some time. So actually transfusing a non-irradiated unit, if they do actually need an irradiated unit, there's a potential for transfusion-associated graft versus host disease. And this is quite rare, but if it does occur, is usually fatal. So our option 3, transfusing an APOS irradiated and an OPOS irradiated. So this meets the patient's irradiated requirement, assuming that it is still relevant and necessary, and it also meets the requirement for the 2 units. So we're still going to ask them to assess between units transfused, but we still immediately have available 2 units of red cells should the patient need to be transfused both those units prior to being able to order further units down. So this prevents delays. But there is also an impact here. If we transfuse an OPOS unit to this patient, then our further testing and subsequent samples, we're going to see mixed field reactions in our grouping technique. So it's not without impact. It still has an impact on the situation, and we still need to be considering this in amongst everything else that we're thinking about when we're providing blood for our patients. So the important thing about this scenario is considering the clinical situation, considering all the information that we've been given, making sure it's relevant, up to date, and clinically required, looking at the time frames for components being given as well, making sure that what we're providing is necessary, is justified, so looking at hemoglobins, making sure they are relevant. If that hemoglobin has been done on a point of care testing process, then getting a full blood count to check and confirm that that hemoglobin is correct. And then looking at how to provide those components. So if we didn't have irradiated components on site and the blood was needed urgently, what else could we do? What are our other options? Well, there is an option using units greater than 14 days old. That reduces the risk of transfusion-associated graft versus host. There's actually no evidence of transfusion-associated graft versus host from units that are greater than 14 days old. So we have other options, we have other possibilities to fit the clinical picture that is in front of us. And also the other thing is many of us work in hospitals where there are actually multiple sites. So we now are University Hospital of Dorset, and we have 2 sites, Poole and Bournemouth sites. So it's remembering that, okay, we're working on the Poole site and we have the stock available on the Poole site, but what about the Bournemouth site? Do they have units that might be suitable for us to use that would be quicker to get than getting units from the NHSBT? Good communication is key in any and every situation. Good communication can have the ability to really improve any situation, whether it's a major hemorrhage situation or a routine request for blood components. Having that good line of communication between the clinical team and the lab staff and talking about the provision, understanding the rationale and the risks is key. Okay, so scenario 2 I want to talk about. So this is actually something based on a scenario that happened here last year. So we have a female patient. She comes into the emergency department. She has no historic data on the limbs, so we don't know her blood group. We receive, in the time she's in ED, we've received 2 group and screen samples, and the second sample has a request for, again, 2 units as soon as possible, the clinical details, HB45 and post-chemotherapy for pancreatic cancer. So, immediate kind of assessment, what do we know right now? So we process those samples on the analyzer because they arrived prior to the request, and the analyzer is unable to interpret the patient's blood group because of the hemolysis in the sample. The analyzer is also unable to interpret the patient antibody screen, again because of the hemolysis. So those samples are so grossly hemolyzed, we're getting all sorts of flags raised on the analyzer, and it cannot give us an interpretation of the antibody screen. We do have both emergency O positive and O negative red cells on site available. So what do we need to do? Well, we need a little bit more information, don't we? We need to think about what we can do as well. So a bit more further detail. So the patient isn't bleeding, but she's unstable and she is symptomatic, which is not surprising with an HB of 45. So the analyzer won't interpret the results. There's the hemolysis flag, and it cannot give a definitive group or antibody screen result. But that doesn't mean to say that there isn't going to be useful information there. The analyzer will show you those results. It will show you the card or cassette. What can you see? Are you able to make out the group, the antibody screen? Are you able to, by eye, get any useful information that could help you moving forward? We've got some more clinical details, but also what's the age of the patient? So let's think, is the patient of childbearing potential? We might discuss with the requester again, haematologist, and also include the RCI now. What are our options for blood component provision? And we're going to think about sending samples off to the RCI for help and investigations. And also looking at what time of day it is and our workload and colleagues around. So are we in the day? Do we have multiple BMS staff that could start looking at sample processing and manual techniques, or are you lone working at night? Do you have other support available? So what are our options? So option number 1 is we don't do anything on site because we can't. So we can't group the sample by analyzer, we can't cross-match, so we just have to send the samples off to the RCI in the hope that with their more in-depth techniques they can provide us with a definitive group and antibody screen result. Option 2 is we do attempt some manual techniques to try and give our best guess at a blood group and an estimate of whether the antibody screen looks like it potentially could have an alloantibody in there or not, but we still send the samples off to the RCI for cross-match and provision of compatible units. Our third option is that we do still attempt these manual techniques, attempt to see what we can ascertain from the samples on site, package up samples ready to send to the RCI, but we revert back to our emergency group O if the patient needs to be transfused, which in this case she does need to be transfused, so she does need some blood more urgently than waiting for the RCI results. So let's look at the kind of potential outcomes from each of those options. So option number 1, doing nothing on site, sending the samples off and waiting for the RCI. Well, this does give us good results, and we will be given suitable red cells that the RCI have issued, but with this low HB and the patient hemolyzing and being unstable, actually waiting, we've got a potential for death here because the patient could deteriorate quite rapidly and we are delaying the provision of red cells. So is this our best option in this scenario? I don't think so. Option number 2, so attempting some manual techniques, looking at that cassette that the machine has brought forward, doing tube groups. I mean, I don't know how many of you still have the ability to manually tube group, but perhaps doing manual techniques again can provide us with some useful information and may be able to give us an idea of whether or not the patient is RHD positive or negative, for example. But still sending off the samples for RCI to provide components. So again, we get a bit more information, but we are still delaying. We're still not providing components for that patient, which is still a delay, which still ultimately could lead to death. So option 3, we do everything we can on site. We're going to look at those cassettes. We're going to attempt some grouping in tubes, try and ascertain what we can, but also we're going to suggest that the clinical area use those emergency Group O units to be able to transfuse the patient. We know that Group O is not going to be ABO incompatible. So, okay, we cannot group the patient, and okay, we cannot identify definitively whether or not the patient has any alloantibodies. But the likelihood of them having an antibody is quite slow, and if we weigh this up against the risk of not transfusing, actually providing the Group O blood is probably going to be the best in this scenario, because it transfuses the patient and doesn't cause delays and doesn't cause potential death from a delay in that transfusion. And as Tim has already mentioned earlier today, delays are one of the biggest causes of death, and as you can see from this extract from the SHOT report, reported incidents of delays are going up and up each year. Now, I don't think necessarily that means there are more delays, but I think what it does mean is that we're getting better at recognising when we are delaying provision of service, recognising that this has a massive impact on clinical service and can have a massive detrimental impact on our patients. So we're trying to learn from these, from these incidents of delay, learn and look at and identify the areas, the gaps where the delays have been caused, and plug them with solutions. I'm not sure if you can read this very well. It's not very big on my screen, but I literally daren't press anything on my screen at the moment, so I don't want to lose anything. So there are a number of reasons why things are delayed, but good communication will go a very, very long way in helping to prevent those delays. So my key messages and takeaway messages are providing something in urgent clinical situations. Delaying and not providing some sort of unit is a massive risk and can lead to death of the patient. So you have to assess all your options. Yes, we need to follow policies and processes and guidance, but we also need to be able to apply that to any clinical situation. And there are going to be situations that you come across in your career where it doesn't sit quite comfortably. You cannot do a group on a patient. You cannot identify the antibody, but you need to provide suitable red cells to transfuse that patient to prevent death from bleeding or death from a lack of red cells. So knowing when and what you need to follow and how you can provide the safest, most appropriate component is what will make you a great BMS. Be clear and concise in your advice and discussions so that the people you are talking to understand the risks, but equally understand the solutions. We can't just say, no, we can't do this, we can't do that, there's this problem and there's that problem. That doesn't help the clinical team. What we need to say is that there are issues, this is the problem, but this is what we're going to provide. This is the most suitable option at this point in time. And use your clinical colleagues for advice as well. So don't forget your colleagues that you're working with and also your haematologist as well for advice. So that's the end of my 2 scenarios. Are there any questions or comments or anything? I'm going to attempt to put the chat on.
Are there any questions from the audience for Vikki? I love the fact also that you highlighted the use of red cells older than 14 days as an alternative to irradiated blood, because I don't think that's ever given as enough of an option.
I agree. I think it's, again, as transfusion scientists, we need to remember all of these tools. So I just see in the chat there, what is the theory behind the 14 days? Well, I don't know 100%. So this is my best guess and my logic behind it. So the reason we get transfusion graft versus host is because the white cells in the donor unit are able and capable, even though it's leukodepleted and there's only a few of them left, those few white cells are capable of mounting an immune response against the patient if the patient is immune compromised. So for you and I, if we are transfused, those donor white cells aren't a problem. But if we're immune compromised, those donor white cells can mount an immune response and can attack the host as kind of like a foreign object. So by making the blood greater than 14 days old, I imagine that the likelihood is those white cells are less viable and less likely to multiply, replicate, and have that immune response against the patient.
Despite the fact that that is just what you think happens, Vikki, I'm pretty sure there's the scientific evidence behind that. So yeah, I completely agree with you 100%. I think all the messages that are coming through your presentations today about the importance of communication is so key. A question has also come up: could the future depend upon synthetic manufactured blood components, and how possible?
Okay, I have very, very limited knowledge on this, okay, but again, the last time I read anything about a kind of synthetic manufactured red cell, and please, any experts on here, feel free to leap in. The trouble is, red cells are amazing. So they uptake oxygen, they transport it, and then they let go of it wherever it needs to be let go of. So whether that's muscles, brain, wherever. And this is the problem. We cannot create or engineer something similar that will uptake oxygen and let it go. So there isn't currently a fake blood or an alternative to red cells. There's lots of things that we do to minimize using red cells. So things like optimizing patients by giving them iron so that their own bone marrow can make red cells, EPO, so erythropoiesis and erythropoietin. We can help stimulate red cell production in patients. We can try and minimize blood loss. So again, things like cell salvage and tranexamic acid to help prevent blood loss. And we can use restrictive triggers and targets, so not transfusing patients unless they absolutely have to be transfused. But at the end of the day, we still don't have a fake blood. We still don't have an alternative to red cells. So, anyone out there who wants a budding career in making fake blood, get on it, because we don't have fake blood yet.
I've just spent 2 days utterly geeking out at a clinical and research and design conference, and there is a really exciting study going on, the Restore study, where they've grown red cells from stem cell lines, and they are transfusing them into patients. So that would be, I'll see if I can pop a link in the chat for that. And also there's great projects, I believe, coming out of Cambridge for universal components with plasma and platelets. So there is a huge amount of innovation. I think actually that's something we should be really proud of in the UK. So yeah, it is really exciting. I'll try and pop some bits in the chat for you guys.